Very good morning, respected Emeritus Chairperson, Mahatma Gandhi University of Medical Sciences and Technology, Dr. M.S. Swarkar sir, Chairman cum Chancellor Dr. Vikas Chandra Swarkar, Vice Chancellor Dr. Ajay Gulati, Pro Vice Chancellor Dr. V.K. Kapoor, Principal Mahatma Gandhi Medical College and Hospital Dr. N.D. Soni, respected senior faculty members, colleagues and students. I welcome you all to the 12th UGCR, that is the 12th undergraduate combined rounds of Mahatma Gandhi Medical College and Hospital. The topic for today's undergraduate combined rounds is Asthma Part 2, which will cover the clinical features, the management and prevention of asthma. The chairperson for today's session is Dr. Suresh Koolwal, Professor and Head of the Department of Pulmonary Medicine. Now, I would like to invite Dr. Suresh Koolwal, sir, Mahatma Gandhi University of Medical Sciences and Technology, for the introduction and brief comments on asthma. Welcome you, sir.
Good morning, respected Dr. M.L. Sankar sir, Dr. V.C. Kapoor sir, and friends. In the last, you have heard about basics of bronchial asthma. Now today we'll be dealing with clinical features and management and allergic rhinitis association with bronchial asthma, prevention of bronchial asthma, and how to do the public in the community prevention in bronchial asthma. Now, as you know, bronchial asthma is a very common disease and very common in children. 50% of the patients in bronchial asthma are in childhood. Now, three main important things are there in bronchial asthma. There is a diffuse airway inflammation, hyperresponsiveness, which results in diffuse airway narrowing. This diffuse airway narrowing causes cough, which is usually episodic and dry cough, chest tightness, breathlessness, and wheezing. Now, 75% of these bronchial asthma patients are also associated with allergic rhinitis. The relation between the allergic rhinitis and bronchial asthma is there because there is a common path, there is a common anatomical structure, continuation structure from the nose to lungs. So it's called one airway, one disease. The etiology is same, pathogenesis is same. If you treat bronchial asthma, it also shows improvement in allergic rhinitis. If you treat allergic rhinitis, it shows improvement in bronchial asthma. Now, all patients of the bronchial asthma cannot be treated with the same line. It is an individualized approach because there are various phenotypes and endotypes of bronchial asthma. Now, with the evolution of the molecular biology, the eosinophil counts are very important in bronchial asthma. So, bronchial asthma on the basis of eosinophil can be divided into T2 high asthma and T2 low asthma. T2 high asthma is asthma which is having atopic nature, where IgE increased, eosinophils are higher, and it's common in childhood. These T2 high asthma patients respond well to the corticosteroids. Then there T2 low asthma. T2 low asthma which has low IgE levels or normal IgE levels or low eosinophil or normal eosinophil levels. This can be neutrophilic asthma or polygranulocytic asthma. So we have different phenotypes: atopic asthma, atopic eosinophilic asthma, eosinophilic asthma, polygranulocytic asthma, and neutrophilic asthma. So now the targeted therapy has come to treat each target and different approach to the different phenotypes. But there is GINA has recommended stepwise treatment of the bronchial asthma, starting from the beta-2 agonist and steroids. Steroids are mandatory even in mild intermittent asthma. Asthma can be seasonal, which is episodic only during seasons, like people who are allergic to the pollens. 80% of the bronchial asthma patients are usually allergic asthma, and these allergies may be seasonal or perennial. Seasonal allergies are because of pollens. Now, in a particular season, if the patient complains of some symptoms, then it is seasonal asthma. And even in the seasonal asthma, the starting is beta-2 agonist and steroids. In the persistent asthma is perennial asthma, which is most common allergen in Indian houses: house dust mite, cockroach, animals, and environmental pollution. Smoking is also one of the irritant of the bronchial asthma, hyperresponsiveness. So you have to, stepwise, you have to increase the treatment. And if the patient has received bronchodilator, has received steroids, has received anticholinergic drugs, and patient is still not improving, then we label it as uncontrolled asthma or uncontrolled severe asthma, where you use targeted therapy. Asthma has no cure, but it can be prevented. The prevention can be primary prevention, secondary prevention, or tertiary prevention. Prevention starts before the birth of child. You do not, atopic mother, if a mother is having asthma, a father is having asthma, there are chances that 75% of their children will have asthma. If the only one parent is having asthma, there are 40% chances that their children will have asthma. So you can prevent the asthma occurring, starting prevention when the child is in the uterus. So in the early childhood and in the pregnancy, you can start prevention, that is primary prevention, not as atopy to develop. But once atopy is developed, you are preventing to develop sensitization, and that is developed asthma, that is secondary prevention. And once the asthma is developed, then you have to prevent the repeated attacks of asthma, that is tertiary prevention. So today we will be covering all these things in various lectures and will be presented by our students. Thank you very much.
A very good morning to respected dignitaries, esteemed faculty members, and my fellow colleagues. Today, under the guidance of Dr. Puneet Rajwani, Professor and Head, Department of General Medicine, and moderatorship of Dr. Manish Pahadia, Professor in Department of General Medicine, alongside my team members, Advika Singh, Aviral Bhati, Mansi Mishra, and Pragya Gabi, I, Isha Gupta, am here to present on the topic Clinical Features and Management of Asthma. When we talk about asthma, the first question that naturally arises is what exactly is it? Asthma is a disease characterized by episodic airway obstruction and airway hyperresponsiveness, usually accompanied by airway inflammation. Asthma presents with various symptoms, including episodic shortness of breath called dyspnea, wheezing, cough, chest tightness, and mucus production. These symptoms may vary in intensity and frequency and are often triggered by specific factors. Here is illustration of how genetic susceptibility and development and exposure during the lifespan interact to produce a disease that can vary in intensity and chronicity. Disease expression is characterized by airway hyperresponsiveness with varying degrees of airway inflammation and airway structural changes accompanied by varying degrees of symptoms that can be influenced by exposures to triggers, that can cause acute deterioration as well as chronic symptoms. Provoking factors are factors that worsen symptoms by causing airway inflammation, hyperactivity, and obstruction. Common triggers include allergen, that can be indoor allergens like dust mites, pet dander, etc., and outdoor allergens like pollen and fungal spores. Irritants include tobacco smoke, strong odors of perfume, air pollution, and chemical irritants. Respiratory infections like common cold, flu, and bacterial infections including Mycoplasma pneumoniae, human rhinovirus can exacerbate symptoms. Physical factors responsible are exercise-induced asthma, especially in cold or dry air. Emotional factors like stress, anxiety, or intense emotions can trigger symptoms. Medications like non-steroidal anti-inflammatory drugs and beta blockers, hormonal changes, menstrual cycle-related asthma, also called perimenstrual asthma, and pregnancy can sometimes affect asthma control. Occupational exposures, dust, fumes, or chemical in workplace, and other triggers like smoke or secondary smoke and food additives can provoke symptoms. Illustrated is a cross-sectional human of bronchus. The left-hand side represents the normal airway. The right represents the asthmatic airway, highlighting the pathologic changes that can be seen in asthma. The asthmatic airway lumen is reduced by smooth muscle constriction, mucus in the airway lumen, and thickening of submucosa due to edema and cellular infiltration. In addition, the ability to the lumen to increase in size with smooth muscle relaxation may be impaired by deposition of collagen. Now let's talk about the diagnosis of asthma. A
A presumptive diagnosis of asthma can usually be made based on the complete history of recurrent wheezing, shortness of breath, chest tightness, and cough. Symptoms may worsen at night or early in morning. Seasonal variations, exercise, or allergen may trigger the primary complaints. In patients with adult onset asthma, use of NSAIDs or beta blockers and ACE inhibitors should be elicited. Now let's go through each primary complaint in detail. Dyspnea is one of the hallmark features of asthma. It is graded using different scales such as modified MRC and NYHA grading systems to assess severity. Modified MRC dyspnea scale is a 5-point scale that measures the severity of breathlessness in daily activities. It is commonly used in chronic obstructive pulmonary disease but can also help assess asthma-related dyspnea. NYHA classification is a 4-class system used to assess the impact of breathlessness on physical activity, mainly for heart failure, but sometimes applied to severe asthma. Dyspnea is a symptom with a wide range of potential causes. These are some of the key differential diagnoses that should be considered while evaluating a patient experiencing dyspnea. These include bronchial asthma, chronic obstructive pulmonary disease, congestive heart failure, myocardial infarction, and pulmonary thromboembolism. Wheezing is a high-pitched musical sound produced during breathing due to turbulent airflow through narrowed and obstructed airways due to inflammation, mucus buildup, or bronchospasm. Common sites of obstruction are the small airways or bronchioles. Here is the diagram depicting difference in normal airway, asthmatic airway, and asthmatic airway during attack. Many asthma patients experience nighttime coughing that can be triggered by cold air, strong soaps and perfumes, dust, smokes and fumes, pollen and animal fur, and cerebrovascular accident. This can significantly disrupt sleep and reduce quality of life. Lab diagnosis of asthma include pulmonary function test, sputum examination, chest radiography, CT scan, and other assessment tools such as eosinophil counts, IgE and skin and radioallergosorbent test, and exhaled nitric oxide. Pulmonary function test, effective reduction of the airway lumen in asthma produces increased resistance to airflow, which can be detected as a reduction in expiratory airflow during forced expiratory maneuvers. The peak expiratory flow rate, forced expiratory volume in 1 second, FEV1, and forced FEV1 by FEC ratio are reduced below the normal limit. Reversibility is defined as a greater than equals to 12% increase in FEV1 and an absolute increase of greater than equals to 200 ml at least 15 minutes after administration of beta-2 agonist or after several weeks of corticosteroid therapy. Diurnal peak flow variability of greater than 20% has also been produced as an indicator of reversible airways disease. Induced sputum may be used in more specialized centers. It helps characterize type 2 and non-type 2 inflammation by detection of eosinophils and neutrophils respectively. This graph represents the flow volume curve in both remission and during the asthma attack. It helps us understand how airflow is affected in asthmatic patients under different conditions. The black line represents the normal curve, while the red line is the curve during asthma attack. Chest radiography is useful to assess the presence of bronchiectasis and other abnormalities causing airway obstruction. Hyperinflated lungs and prominent bronchovascular margins are seen. CT scan presents with air trapping and bronchial air thickening. The National Institute of Health and Care Excellence, NICE, has established criteria to aid the diagnosis of asthma. These criteria rely on objective lung function tests to improve diagnostic accuracy. Spirometry findings. Spirometry is a key diagnostic tool for asthma. FEV1 by FEC ratio below 80% suggests airway obstruction. Sensitivity 52%, specificity 72%, meaning it is more specific than sensitive, so a positive result is more reliable than a negative result. Fractional exhale nitric oxide testing, FeNO levels above 22 ppb indicate airway inflammation. Sensitivity 57%, specificity 87%, making it highly specific for eosinophilic exacerbation and asthma. Peak flow variability, diurnal peak flow variability over 2 weeks greater than 12 to 36% supports an asthma diagnosis. Sensitivity 50%, specificity 72%, meaning it is useful but not definitive on its own. Asthma can sometimes be confused with cardiac conditions. Let's differentiate between bronchial and cardiac asthma. Bronchial asthma is caused by airway inflammation and is treated with bronchodilators and corticosteroids. Cardiac asthma, on the other hand, results from heart failure, leading to fluid buildup in lungs. It is treated with diuretics and heart medications. Asthma is classified based on symptom frequency and severity. Intermittent asthma, symptoms occur fewer than 2 days per week. Mild persistent, symptoms occur more than twice a week but not daily. Moderate persistent, symptoms occur daily with frequent nighttime awakings. And severe persistent, symptoms are present throughout the day with frequent flare-ups. Managing asthma effectively is crucial to prevent symptoms, reduce exacerbations, and improve the quality of life for patients. Asthma management is based on stepwise approach that includes confirming the asthma diagnosis, ruling out alternative diagnosis, identifying disease mechanism for targeted treatment, identifying and managing provoking factors and comorbidities, improving quality of life. Both patient and family participation is important and regular follow-up is required. Pharmacotherapy of asthma, it includes 5 classes of drugs: short-acting beta agonist, long-acting beta agonist, long-acting muscarinic antagonist, steroids that can be taken orally or inhaled, and methylxanthine. Short-acting beta agonists stimulate beta-2 receptors in bronchial smooth muscles and cause bronchodilation. These include salbutamol, levosalbutamol, and phenytoin. Side effects are tachycardia, tremors, and anxiety. Long-acting beta agonists bind to beta-2 receptors in bronchial smooth muscles and provide long-term airway dilation. Example, salmeterol and formoterol. Side effects are tachycardia, tremors, anxiety, coughing, and throat irritation. Long-acting muscarinic antagonists block M3 receptors in bronchial smooth muscle and cause bronchodilation. Examples are tiotropium, eclidinium, glycopyrronium, and umeclidinium. Side effects are dry mouth, cough, throat irritation, constipation, and blurred vision. Steroids reduce inflammation by inhibiting cytokine release and suppressing immune activity. Inhaled steroids include fluticasone and budesonide, and orally taken are prednisone and prednisolone. Side effects are weight gain, hyperglycemia, and bone weakness. Methylxanthine inhibits phosphodiesterase, increase CAMP levels, and blocks adenosine receptors, causing bronchodilation. Examples are theophylline and aminophylline. Side effects are nausea and vomiting, headache, and palpitations. Drugs of asthma can be classified into reliever and controller or preventers. Relievers relaxes the airways, and improves acute symptoms of cough and breathing difficulty. These include short-acting beta-2 agonists, examples salbutamol, terbutaline, and theophylline, anticholinergics like ipratrobutamine and bromide. Controllers or preventers reduces airway swelling and improves symptoms in long term and prevent future episodes. Examples are corticosteroids like budesonide and fluticasone, long-acting beta-2 agonist, combinations of ICS and long-acting beta agonist, sustained release theophylline, non-steroidal anti-inflammatory drugs, and anti-IgE. The different inhalation drug delivery systems are used for asthma. These include nebulizers, metered-dose inhalers or MDIs, dry powder inhalers or DPIs, and spacers. Nebulizers are devices that convert liquid medication into a fine mist, allowing deep lung penetration. They are useful for patients who struggle with inhalers, particularly during severe exacerbations. MDIs or metered-dose inhalers, these deliver aerosolized medication using a propellant. They provide rapid onset of action and portable and convenient for daily use. Dry powder inhalers or DPIs. These use the patient's own inhalation effort to deliver micronized dry powder medication. They do not require a propellant and ensure mold and deposition in patients with adequate inhalation effort. Space inhalers, a type of DPI that rely on the patient's breath for medication release. They are easier to use than MDIs and they do not require hand-breath coordination. Each system has distinct advantages and the choice depends on patient preference, lung function, and disease severity. Certain medical conditions can make asthma harder to control. These include chronic rhinosinusitis with or without nasal polyps, obesity, which affects lung function, gastroesophageal reflux disease, which can worsen symptoms, and conditions like COPD, anxiety and depression, and sleep apnea also contribute to poor asthma control. To summarize, asthma is chronic inflammatory disease affecting the airways. Identifying and avoiding triggers is key. Pharmacological therapy includes controllers and relievers. Comorbidities must be managed effectively, and personalized treatment plans improve outcomes. Thank you. Now I would like to hand over the slide to the Department of EM.
She used two terms in her presentation. One was sensitivity and other was specificity. All of you are going to become doctors sooner or later. You will take history and examination, then you will ask for some tests.
Good morning, respected dignitaries.
Yeah, yes. In the earlier lecture, you mentioned about CT scan. So, what are the findings in CT scan in bronchial asthma you have?
Good morning, respected dignitaries, teachers, and fellow colleagues. Today, I, Svasti Singh, along with my batchmates Mokshi Ramrathani, Pallavi Anjana, Pranjal Mathur, and Saksham Modi, under the guidance of Dr. Tarun Oja, Professor and Head, Department of ENT and Head and Neck Surgery, and Moderator Dr. Nikhil Soni, Associate Professor, Department of ENT and Head and Neck Surgery. So, second. Will be representing the Department of ENT. Our topic for today is Unified Airway Diseases. Unified airway hypothesis is an established concept that the upper and lower airways form a single unified organ which is interconnected and interrelated by several physiologically important shared traits such as immunology, pathophysiology, epidemiology, and clinical characteristics. This gives rise to one airway, one disease. The upper airway diseases include allergic rhinitis, chronic rhinosinusitis with or without nasal polyps, and non-allergic rhinitis. The lower airway diseases are asthma, chronic obstructive pulmonary disease known as COPD, and bronchiectasis. In our presentation, we will be studying the correlation and interdependence of allergic rhinitis and asthma on each other and how the management of one can control the other. The causative allergens include indoor allergens and outdoor allergens. The indoor allergens include dust mites, which are most prevalent indoor allergens and are found in carpets, bedding, and furniture. The pet dander can be found in dogs and cats. Mold spores can grow in damp areas of the house, hence it is advised to use dehumidifiers, and cockroach droppings can trigger allergens in some individuals. The outdoor allergens are majorly comprised of tree pollen, grass pollen, and weed pollen. Tree pollens are found in neem, mango, casuarina, and banyan. Grass pollen are found in Bermuda grass, rye, orchid, and red top. The weed pollen can be found in Parthenium hystrophorus, which is also known as carrot grass. Pollen allergy is an immune system reaction to pollen, a fine powder released by plants to fertilize other plants. It is also known as seasonal allergic rhinitis or hay fever. It occurs when harmless water-soluble proteins enter the mucous membrane of the nose, eyes, and the mouth. We will now be discussing the ARIA Guidelines 2020. ARIA stands for Allergic Rhinitis and its impact on asthma. It is a non-governmental organization which collaborates with the World Health Organization and releases some management strategies for asthma as well as allergic rhinitis. The classification of allergic rhinitis according to ARIA is based on symptom duration as well as severity. On symptom duration, it can be classified into intermittent as well as persistent. Intermittent symptoms last less than 4 days a week and less than 4 weeks a year. However, the persistent symptoms last more than 4 days a week and more than 4 weeks a year. The severity can be classified further into mild and moderate to severe. The mild symptoms do not interfere with daily life. However, the moderate to severe symptoms can affect sleep, performance, and daily activities. The relation between allergic rhinitis and asthma is that they both often coexist because of their commonality. The relation between allergic rhinitis and asthma is that they both often coexist because of their involvement in the chronic airway inflammation. Up to 80% of asthma patients have allergic rhinitis, and thus the treatment of allergic rhinitis can significantly improve asthma control. Allergic rhinitis can trigger asthma symptoms by increasing the bronchial hyperreactivity. We shall now discuss the integrated treatment approach or the stepwise management for ARIA guidelines 2020. The first category is allergen avoidance. As discussed earlier, the allergens can be classified into indoor allergens as well as outdoor allergens. The indoor allergens can be avoided by use of HEPA filters and reduced humidity, preventing dust, mites, and mold exposure. The outdoor allergens can be avoided by monitoring the entry of pollen, dust, and insects in the house. The irritants can be avoided by avoiding smoke, strong odors, as well as air pollution. The pharmacological treatment includes intranasal corticosteroids, which are the first-line treatment. The examples of intranasal corticosteroids are fluticasone, budesonide, mometazone. These are effective for nasal congestion as well as inflammation. The next category of drugs are oral and intranasal antihistamines. These are loratadine, fexofenadine, cetirizine as a last name. These are effective for sneezing as well as runny nose. The leukotriene receptor antagonists are montelukast, which are useful in patients with allergic rhinitis as well as asthma both. The next category are decongestants, which are used for short term only. Their use must not exceed for more than 3 to 5 days in order to avoid rebound congestion. These examples are oxymetazoline, pseudoephedrine, and are used in severe nasal congestion. The allergen immunotherapy, also known as AIT, is used for moderate to severe allergic rhinitis, which is not controlled by medication. Sublingual or subcutaneous routes help to reduce long-term sensitivity. The asthma management in ARA guidelines says that we must follow GINA guidelines or the Global Initiative for Asthma, which has been touched upon by the Department of Medicine. Inhaled corticosteroids are the first-line treatment for persistent asthma. Combination therapy, which includes inhaled corticosteroids as well as long-acting beta agonists, are used for moderate to severe asthma. Beta blockers and NSAIDs are to be avoided if they trigger symptoms. Lastly, we shall be touching upon Samter's triad or the aspirin-exacerbated respiratory disease or AERD. The Samter's triad involves aspirin sensitivity, bronchial asthma, as well as nasal polyps. Aspirin sensitivity includes other non-steroidal anti-inflammatory drugs such as ibuprofen as well as naproxen. Bronchial asthma, however, only a small number of people with bronchial asthma are found to develop AERD and nasal polyps even after their removal by surgery. The cause of AERD is not exactly known. It is not an allergic reaction or transferred by genetic causes. However, the use of aspirin can worsen the symptom, but it is not caused due to its intake only. The symptoms of Samter's triad are intolerance to alcohol, chronic sinusitis, asthma, loss of sense of smell, nasal polyps, as well as congestion. Thank you. I would now like to call upon the Department of Emergency Medicine to continue.
Good morning to one and all present here. Today I, Aru Jain, am going to present on the topic of status asthmaticus, representing the Department of Emergency Medicine, on behalf of my team of Harsh Jain, Garv Agarwal, Rashida Bansal and Apurva Khichi, under the guidance of Dr. Suchita Vaya Ma'am, Professor and Head of Department of Emergency Medicine, with our moderator, Dr. Revat Agarwal Sir, Assistant Professor, Department of Emergency Medicine.
Asthma is a chronic inflammatory condition of the airways characterized by airway hyperactivity, inflammation, bronchoconstriction, and mucus secretion. Status asthmaticus is prolonged severe episode of asthma that is unresponsive to initial standard treatment that may lead to respiratory failure. The following clinical findings are helpful in identifying patients experiencing acute asthma attack. Symptoms like inability to lie supine, inability to speak, diaphoresis, chest pain, and wheezing. There is also increased work of breathing, leading to use of accessory muscles of inspiration. Patient may also present with mental status changes such as agitation, confusion, and fatigue. There are vital signs such as tachypnea, greater than 30 breaths per minute, tachycardia with heart rate greater than 120 beats per minute, and pulsus paradoxus. Now, on the basis of severity of acute asthma attack, it can be classified into mild, moderate, and severe attack and respiratory arrest. Our emphasis today will be on severe acute attack and respiratory arrest, as these are medical emergencies. In severe acute attack of asthma, patient is agitated and hunched forwards and can only speak in words due to breathlessness at rest. There is increased respiratory rate with more than 30 breaths per minute, loud wheezing, and use of accessory muscles of inspiration. On the other hand, a patient in respiratory arrest has difficulty in speaking, is drowsy and confused, and does not use accessory muscles of inspiration due to fatigue. Respiratory rate here is either very high or decreasing due to fatigue, wheezing is absent, and there is silent chest on auscultation. Pulse is greater than 120 mmHg, and pulsus paradoxus is usually present in severe attack, whereas there is bradycardia and respiratory arrest, and there is absence of pulsus paradoxus due to respiratory muscle fatigue. PEFR, or peak expiratory flow rate, is less than 60% in severe cases and less than 33% in respiratory arrest. In the Department of Emergency, the assessment of severity of attack is usually done by arterial blood gas analysis, PaO2, PaCO2, and SaO2. PaO2 is less than 60 mmHg and SaO2 is less than 90%. PaCO2 is slightly increased, that is more than 45 mmHg in severe attack and 50 to 60 mmHg in respiratory arrest. PaCO2 significantly increases in respiratory arrest when it is imminent, as the respiratory drive significantly reduces and the patient is not able to completely exhale out the CO2. When such a patient arrives in emergency, a quick primary survey is conducted in the form of A, B, C, D, which refers to airway, breathing, circulation, and disability. For airway, we need to assess if it's patent or obstructed. Suitably, administration of supplemental oxygen is done to maintain SpO2 greater than 90% in adults. In cases of life-threatening asthma, intubation is done. For breathing, we check for use of accessory muscles, and ventilation can be done using permissive hypercapnia. C stands for circulation and refers to optimization of cardiac output with IV fluid bolus or inotropic support. Lastly, disability refers to altered mental stage, which may indicate hypoxia, hypercapnia, or exhaustion. It is assessed by AVPU, Alert Verbal Pain Unresponsive Scale, or GCS, which is Glasgow Coma Scale. Now, let's discuss this flowchart, which outlines the stepwise management of asthma exacerbation. After we do a quick primary survey of ABCD, we start by performing an initial examination in which we take detailed patient history, do a physical examination, and other tests. Mild to moderate and severe asthma is treated by supplemental oxygen, SABA, or short-acting beta-2 adrenergic agonists, and oral systemic corticosteroids. After which, reassessment is done, resolved patient is discharged, and the rest are classified into either moderate exacerbation or severe exacerbation. In moderate exacerbation, inhaled SABA is given every 60 minutes along with oral corticosteroid. This is continued for 1 to 3 hours. Severe exacerbation is treated by oxygen, nebulized SABA plus ipratropium, corticosteroids, and adjunct therapies. Response of treatment to this either may be good, incomplete, or poor. Incomplete or poor response may lead to respiratory arrest, in which 100% oxygen is used for intubation and mechanical ventilation, along with IV corticosteroids, SABA, and ipratropium bromide, followed by admission to ICU. These drugs are commonly used to treat acute severe asthma, SAVAs, such as salbutamol, which are given every 20 minutes for a total of 3 treatments in the first hour. Systemic beta-2 agonist therapy, such as epinephrine and terbutaline, are used as rescue strategy to minimize respiratory failure and intubation. Anticholinergics like ipratropium bromide are also used as bronchodilators. Systemic glucocorticoid therapy is essential for airway inflammation and mucus plugging. Magnesium sulfate is used as an adjunctive treatment in severe cases that do not normally respond to standard therapies. Its use is supported in emergency setting, especially for life-threatening asthma. Now, in severe cases, mechanical ventilation reduces the work of breathing and enables the patient to rest while airflow obstruction is resolved. It may be either invasive mechanical ventilation or non-invasive mechanical ventilation. Indications for ventilation are cardiac or respiratory arrest, progressive somnolence or agitation, to speak, evidence of worsening respiratory fatigue, increasing tachycardia, worsening diaphoresis, worsening intercostal retraction, rising PCO2 greater than 55 to 70 mmHg, respiratory acidosis less than 7.2, and severe hypoxia. Finally, coming on to the disposition of the patient from the ER, there may be 3 possible outcomes on the basis of severity of patient's condition and response to treatment. That is, they may be discharged, admitted to the hospital ward, or admitted to the ICU. Patients with severe asthma exacerbations or status asthmaticus who are at risk of respiratory failure are required to be admitted to the ICU. The following interventions are typically necessary: oxygen therapy, inhaled SAVA therapy, which is delivered hourly or continuously with the help of a nebulizer, IV corticosteroids, and adjunct therapies such as magnesium sulfate and ketamine. Possible intubation and mechanical ventilation is also to be done here. Thank you. Now I'd like to call the Department of Physical Medicine and Rehabilitation.
Good morning, respected dignitaries, teachers, and my dear juniors. I am Dr. Koyali, third year PG resident from the Department of Physical Medicine and Rehabilitation. I'll be presenting on pulmonary rehab in asthma under the guidance of Dr. Sonu Singh, professor in PMR. So first is the definition of what is pulmonary rehabilitation according to the American Thoracic Society and European Respiratory Society have adapted the following new definition of pulmonary rehabilitation, which is a comprehensive intervention based on the thorough patient assessment followed by the patient-tailored therapies that include but are not limited to exercise training, education, and behavioral changes designed to improve the physical and psychological condition of the patient with chronic respiratory disease and to promote the long-term adherence to the health-enhancing behaviors. So the benefits of the pulmonary rehabilitation is it does not reverse nor have any direct effect on the primary respiratory pathophysiology, yet it has proven to improve the following, that is, it reduces the respiratory symptoms, that is dyspnea and fatigue, it increases the exercise performance, it increases knowledge about the pulmonary disease and its management, it improves health-related quality of life, it improves psychosocial symptoms, that is reversal of anxiety, depression, and increased self-efficacy, and it reduces hospitalization and use of the medical resources and return to the work for some patients. So pulmonary rehabilitation components, first is the education. We have to educate the patient about the breathing strategies, proper lung function measures, and also about the light breathing techniques, how we should breathe, and avoid of the exercents like smoking, and also to participate in the rehabilitation program. Second is the early exercise training that we'll be discussing in the further slides. Then breathing and retraining. It means that breathing, after breathing, we have to also retrain the patient, and we have to continuous breathing has not to be done. And nutritional advice in the form of taking of high protein and carbohydrate diet so that patient can participate in pulmonary rehabilitation. Then is the psychological support of the patient. and outcome assessment, which we'll be discussing in further slides. First is this is the structure of pulmonary rehabilitation program, in which we will do proper patient selection, like if there is the symptomatic chronic respiratory disease, or patient is stable and there is functional limitations, and the patient is motivated to do the exercises and rehabilitation, and patient has an energy capacity to perform, and patient is willing to participate, and he wants to do it so that he can do his daily activities. Then is the patient assessment. We'll assess the patient in the form of like activity of daily living of the patient. We'll do pulmonary function test. We'll do ABG, oxygen saturation, 6-minute walk test of the patient, and then individualization of the program. After doing this, we'll prescribe exercise training in the form of limb and arm exercises. This will be scheduled for a few sessions and for a few weeks. Then calorie supplementation, strengthening exercise, anaerobic steroids may be given, self-management education, and psychological aspects like depression and anxiety, which we have to treat. Further, after these 4 things, we will do outcome assessment like symptom assessment, exercise performance and quality of life in the form of SF36 and 6-minute walk test. So guidelines says that the minimum of 20 sessions should be given, that is for 6 to 12 weeks, at least 3 times per week, twice weekly supervised plus 1 unsupervised home session may also be acceptable. Once weekly sessions seems to be insufficient. Each session to last 30 minutes. It can be for 10 to 45 minutes depending upon the patient's acceptance and performance. High intensity exercise provides greater physiological benefit and should be encouraged. However, low intensity training is also effective for those patients who cannot achieve this level of intensity. Both upper and lower limb training should be utilized, like lower extremity exercise like treadmill and stationary bicycle ergometer, and upper limb exercises like lifting weights and arm cycle ergometer are recommended. The benefit of endurance and strengthening training generally have multiple beneficial effects and is well tolerated. Strength training would be particularly indicated for the patients with significant muscle atrophy. Respiratory muscle training could be considered as adjunctive therapy, primarily in the patients with suspected or proven respiratory muscle weakness. The minimum length of the effective rehabilitation program is 6 weeks. Daily to weekly session. Duration is for 10 minutes to 48 minutes. Intensity of 50% of the oxygen, maximum oxygen consumption to maximum tolerated. Endurance training can be accomplished through continuous and intensive exercise programs. The latter involves the patient doing the same total work but divided into briefer periods of high intensity exercise, which is useful when performance is limited by other comorbidities. Additional consideration, optimal bronchodilator therapy should be given prior to the exercise training to enhance the performance of the patient. Patients who are receiving long-term oxygen therapy should have their continued during the exercise training, but may need increased flow rates. Oxygen supplementation during the pulmonary rehabilitation, regardless of whether or no oxygen desaturation during the exercise occurs, often allows for the higher training intensities and or reduce the symptom in research settings. So outcome assessment is done by providing the patients with an opportunity to give feedback about the program, is a useful measure of quality control. Patient feedback also allows coordinators to evaluate the components of the pulmonary rehabilitation that patient finds most useful. The questionnaire should also provide patient with a variety of answering options, and exercise capacity measurement, which is most important. Last is the mnemonic, which we can give like what fits your busy schedule better. It must be either it is an exercise 1 hour a day or being there 24 hours a day. Thank you. Now I will like to invite Department of Community Medicine to proceed further.
Good morning, everyone. Today, I, Diya Mittal, will be presenting for the Department of Community Medicine on the topic National Program for Prevention and Control of Non-Communicable Diseases under the guidance of Dr. Rajat Vora, Sir, Professor and Head of Community Medicine, and moderator Dr. Archana Paliwal, Professor, Community Medicine. Along with my batchmates, Lavina Manitwal, Devyani Vyas, Manaswini Sharma, and Aditya Bensla. NCDs, non-communicable diseases. These are non-transmittable diseases which may include a wide spectrum of medical disorders, both acute and chronic, like cancers, diabetes, hypertension, cardiovascular diseases, strokes, chronic kidney diseases, chronic obstructive pulmonary diseases, asthma, non-alcoholic fatty liver disease, and a gamut of other diseases. As per WHO, the NCDs are collectively responsible for more than 70% of all deaths globally. NCD has been responsible for a huge out-of-pocket expenditure for populations all over the world. The economic output loss due to NCD, excluding mental condition, is about $3.55 trillion for India for the period of 2012 and 30, indicating the huge financial burden it puts on a developing nation like India. The program falls under the guidance of Sustainable Development Goal 3, that is Good Health and Well-being, with target 3.4, aims at reducing premature mortality from NCD by 1/3 by 2030 in the world and need to promote mental health. It also stresses on the prevention and control of alcohol use. These graphs signify the mortality and the burdens that NCDs put on the nation. As per WHO NCD India Profile 2018, NCDs are estimated to account for almost 63% of all deaths in the country, of which cardiovascular diseases lead with 27%, overall mortality cause followed by the chronic respiratory diseases at 11%, cancers 9%, diabetes 3%, and others. Talking about the burden NCDs put on India are diabetes at 65 million, asthma at 38 million, COPD 55 million, cardiovascular diseases at 54.5 million, with others. Talking about the COPD and asthma particularly, the primordial and the primary preventions include avoiding smoking and air pollution, exercising regularly, eating healthy food, yoga, visiting doctor regularly, use of masks on road and public spaces, and also a point a doctor mentioned in the beginning, the primordial prevention from the mother begins at high-risk patients genetically. The secondary and the tertiary prevention includes early diagnosis by PFT, CXR, ABG analysis, alpha-1 antitrypsin. Specific treatment includes bronchodilators, IV inhalational steroids, and theophylline. The pulmonary rehabilitation programs, oxygen therapy at home, and steam inhalation. The evolution of NCD of the program, it came into being in 2010 and was named NPCDCS, that is National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases and Strokes, launched in 100 districts and 21 states, followed in 2013 and 14, it scaled up in a phased manner to cover all districts of the country and subsumed under the National Health Mission. In 2016, initiated population-based screening of common NCDs as a part of comprehensive primary health care. And in recently, 2023, NPCDCS was renamed as NPNCD, known today as National Program for Prevention and Control of Non-Communicable Diseases, with the inclusion of COPD, CKD, NALFT, and STEMI. The main objectives of the program are health promotion through behavioral change and involvement of community, civil society, community-based organizations, media, development partners. Screening, early diagnosis, management, referral and follow-up at each level of healthcare delivery to ensure continuum of care. Build capacity of healthcare providers at various levels of prevention, early diagnosis, treatment, follow-up, rehabilitation, IEC, BCC, monitoring and evaluation and research. Strengthen supply chain management for drugs, equipment and logistics for diagnosis and management at all healthcare levels. Monitoring, supervision, evaluation of programs through proper implementation of uniform ICT application across India. The organizational structure of NPNCD is at the National NCD Division headed by the Joint Secretary, NCD, Ministry of Health and Family Welfare. Then State NCD Division headed by the Mission Director, National Health Mission. District NCD Division headed by the District Nodal Officer or the District Program Officer NCD. The functions under different organizations are at National NCT Division, monitoring and joint supportive supervision mission visit to union states and territories. Then State NCT Division ensures presence of human resources and maintains district-wise epidemiological profile. District NCT Division organizes capacity building training at all levels of human resources. The strategies employed are health promotion of prevention and reduction of risk factors, screening, early diagnosis, management, referral, follow-up of common NCDs, capacity building of healthcare providers, evidence-based standard protocols, uninterrupted drug and logistics supply, task sharing and people-centered care, information system for data entry, longitudinal patient records, monitoring, supervision, evaluation and surveillance, including technology-enabled interventions, multi-sectoral coordination and linkages with other programs, implementation, research and generation of evidences. The human resources that are employed at the community level is the ASHA, at the sub-center level is the CHO, MPW females, MPW males. At the PHC or the UPHC levels, we have MPW females, staff nurses, lab technicians, pharmacists, and medical officers. At the CHC or the UCHC level, we have physicians, MO, dentists, staff nurses, counselors, dietitians, physiotherapists, lab technicians, and pharmacists. At the SCH or the district hospital level are the physicians, MD doctors, medical officers, dentists, staff nurses, counselors, dietitians, physiotherapists, and lab technicians. Now, the mechanism employed for the program is population-based screening. The data is collected from three main sources, that is the National NCD portal, Clinical Decision Support System, CTSS, Integrated Patient Pathway, APHWC portal, which is followed by the monitoring, supervision, and evaluation. The program monitoring and evaluation cycle requires identification of national and sub-national level of indicators that measures the inputs, processes, outputs, outcomes, and impacts, followed by the process of surveillance, which key objectives are to trigger public health control measures, identify changes in the chronic disease presentation and its risk factors, changes in health practices, and facilitate planning and implementation of the program. A few other programs with linkages with the NP-NCDR, Joint TB Diabetes Collaborative Activities, National Program for Palliative Care, integration with National Urban Health Mission, National Oral Health Program, National Tobacco Control Program, National Program for Health Care of Elderly, Ayushman Bharat Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, Rashtriya Bal Swasthya Karyakram. Summary. With the increasing morbidity and mortality due to non-communicable diseases in the country, the health delivery system is facing a major challenge to provide a set of services for prevention and control of these common NCDs. The National Program for Prevention and Control of Non-Communicable Diseases, NPNCD, provides comprehensive services for early diagnosis, treatment, follow-up, referral under the umbrella of National Health Mission, population-level intervention for prevention, control, screening, and management of common NCDs. Important components of services to be provided by the Health and the Family Welfare Centers under the Ayushman Bharat scheme. Thank you.